I'm Jonah Comstock, editor-in-chief of Pharma Forum. I'm here at LSX in Boston, and I'm joined by James Graham, the CEO of Recce Pharma.
That's it, Recce Pharmaceuticals. Good to be with you.
Yeah, thanks so much for joining me. So tell me a little bit about Recce. You guys are in the antimicrobial resistance space, right?
We are. So we're a late-stage clinical company where we've got clinically the most advanced new class of antibiotic in the world at this time, according to World Health Organization and Pew Charitable Trusts. So but to my knowledge, the only qualified infectious disease designated compound for sepsis, for bacteremia, so the broad spectrum nature of sepsis. But whether it be a registrational phase 3 study for diabetic foot infections, a phase 2 study for broad spectrum septic infections or urosepsis, topical burn wounds with the US Department of Defence, or any of other compounds coming through. It's a very active time for a little Australian company getting ahead.
I've written a lot about AMR and how hard it is to make progress in a space where there's so many misaligned incentives and reasons that doctors want to keep using the antibiotics that they are using. They don't want to pay for new ones. So how do you guys make a business model in that space?
Look, we're focused upon unmet medical needs, so needs not serviced by any existing drugs. So you look to, by example, diabetic foot ulcer infections. If you have diabetes, you've got 48% chance of getting a diabetic ulcer and 80% chance of that getting infected. So it's a big patient population. There are no approved therapies specifically for diabetic foot ulcer infections. You typically try to take a couple of generics and you have a poor outcome for a lot of reasons, both clinically and also mechanism of action focused. So how do you make money in it? Large patient populations, unmet medical needs, and with a superiority to anything that may otherwise touch that.
Even with all that, you still have to convince the payers to pay for it, right? And the providers to adopt it. I mean, is it more challenging than other kind of pharma?
Well, it's you don't have to be greedy, to be honest, in our space. So maybe you do for existing therapies, but for a compound that's entirely synthetic, it's a polymer. We use a method of synthesis, really, really low cost of goods, 100% yield. Our registrational phase 3 study, by example, is in Indonesia. So you go 280 million people in Indonesia, 11% have diabetes, 48% get foot infections. And when you break it all down and then you go, okay, can they afford it? Well, 11% coincidentally of that patient population is in the high net worth category. And where you have a compound with a high net worth category, with a major unmet medical need, yeah, I think they can afford it.
So we talked a little bit, in one of the panels this morning, they talked a little bit about kind of biotech hubs and the benefits of being in Boston versus in Europe. Tell me a little bit about why you guys are in Australia and how you find that in terms of sort of like the resource availability and things like that. Funding.
Yeah, look, funding is a fantastic one in Australia. So by example, we have the Australian R&D rebate. So 43.5 cents of every dollar we expend on R&D applicable activities, the Australian government actually gives us that back in true dollars, caveat-free, non-dilutionary cash. So we recently did a capital raise, by example, of around $10 million US dollars in true cash runway. Well, that's a good, 14.5-ish million of actual cash runway, of that 4.5 being non-dilutionary cash. Australia really, some would argue, but Australia did invent the first penicillin, by example. That was a discovery out of Australia that went to the UK to really be commercialised. And for what it's worth, Pfizer was actually the ones who really put the money in, and that's how Pfizer was created. So Australia's got an incredible inventive capability, but the patient population and market is beyond. I mean, we're 26 million people. Your California here is a larger population than our whole country. But we do, we have partners here that we work with, by example, out back in Massachusetts. It's a global health need, and we certainly position for that.
Tell me a little bit about how far along you are
Yep.
as a company. How close are you to phase 2, phase 3 market, all that kind of stuff?
Sure thing. So we've got a registrational phase 3 study, which is a topical study. So that's as a gel formulation for diabetic foot ulcer infections. We've completed a 1B, 2A for uroseptic patients. So that's an IV fast infusion study. We know through our mechanism of action studies that we work faster than any other antibiotic known to date. So we really get into the body and we attack the bacteria, because there's no such thing as good bacteria in your blood, no such thing as good bacteria in your bladder. So that'll move to a phase 2b study. We've got a ABSSSI study, so acute bacterial skin structure infection study in Australia this time, which is a phase 2 study. And then last but not least is our US Department of Defense burn wound study. We received a $2 million US $2 million grant where we're now working with the US Department of Defense in burn wounds. So we take a portfolio approach which gives the upside opportunities, protects the downside, but really caters to the commonality of bacterial infections in their respective forms.
So we've just started really the conference,
Yeah.
but I know you came from an AMR conference in Philly. So anything interesting you've seen or heard here or there? Anything you
Well, we
learned?
delivered the opening address at the World AMR Congress, so the World Superbug Congress effectively, and really we're positioned as a sign of new hope in the fight against superbugs. World Health Organization has stated that in a recent clinical pipeline. What did we see? Frankly, we would have liked to have seen more. The pipeline has never been drier, the need has never been greater, and our compound and company is really positioned at the forefront of the sign of that new hope in the fight against superbugs.
Awesome. Well, thank you so much for chatting with me today, James.
Thank you.
And it's really interesting to learn about what you do.
Thank you very much. Pleasure.